Dear colleagues in the room and also those attending this webinar virtually, good morning, good afternoon, good evening, depending on your timeline. My name is Dr. Tesfai Tufa, and I'm the director of St. Paul Institute for Reproductive Health and Rights. Warm welcome to the first global SRHR webinar, which is organized by SPHERE in collaboration with St. Paul Hospital Millennium Medical College. St. Paul Institute for Reproductive Health and Rights, since its establishment, has been engaged in research, clinical service, advocacy, training, and education. We are starting this global SRHR webinar to address sexual and reproductive health issues to help clinicians, policymakers, researchers, leaders, and advocates across the world to have an updated knowledge in the area. Issues that create clinical dilemma will be discussed by experts in the field, and recommendation will be shared. Bold and contemporary SRH issues and new research findings in the area will be reviewed and debated. The platform will be open for worldwide academicians, policymakers, research leaders, and clinicians, not only to be an audience, but also to present their work and share their experience. The webinar will be broadcasted on a regular basis every 6 weeks, and I invite everyone to be part of this webinar. I want to take this opportunity to thank St. Paul Hospital, head of the OB/GYN department, and also the Family Planning Fellowship Program Coordinator at the hospital for accelerating this effort, starting from the inception of the idea until now. I hope you will enjoy this webinar and also get a knowledge from it. Without further ado, I want to invite Dr. Delayo Belkala, the head of Department of OB/GYN, to make an official opening remark.
Thank you, Dr. Tesfai. Good morning, good afternoon, and good evening, colleagues. On behalf of the Department of Obstetrics and Gynecology at St. Paul's Hospital Millennium Medical College, I welcome you to this global webinar on sexual and reproductive health organized by the SPHERE. In this era of rapidly changing science and healthcare, such sessions are crucial to update providers with the latest evidence and to foster evidence-based care. So this will be a forum to share this latest evidence, to experience and learn from each other. I would like to thank SPHERE for taking the initiative and organizing these sessions, and I'm sure that this one will be the first of the many more to come in the future. I ask everyone attending the sessions to utilize them maximally, to interact, and to invite more of your colleagues to attend the subsequent coming sessions, and also give us feedbacks on how to improve them. And I hope this will be a very fruitful platform for everyone. And I wish this first session to be a successful event and to have a successful deliberation. Thank you.
Thank you very much, Dr. Delayo, for the opening remark. So now I will call upon Dr. Farid Abbas, Family Planning Fellowship Director at St. Paul Hospital Millennium Medical College, as well as a Family Planning and Reproductive Health subspecialist, to invite a speaker.
So today we will have our first session on, Dr. Lemi will give us the first session on Global SRH lecture series. So Dr. Lemi is a medical doctor, assistant professor of OB/GYN and family planning and research specialist. He is a researcher, trainer, academician, and reproductive health and justice advocate. He has published more than 30 articles on reputable peer-reviewed journals. Dr. Lemi also participated on the production of several SRH guidelines and protocols and training materials, including the WHO abortion guidelines. He is also serving as the Ethiopian representative of the World Association of Trainees in OB/GYN. Dr. Lemi is currently as assistant professor of OB/GYN at the Department of Obstetrics and Gynecology. He is also the clinical service vice head of the department. Today, Dr. Lemi will take us through termination of pregnancy in women with uterine scar. This is one of the topic of major debate among many providers, obviously for many, many reasons. And Dr. Lemi will walk us through the evidences in the clinical practice on the subject matter. After our session, this will be followed by Q&A, and please also feel free to drop your questions on the Zoom chat. Thank you. Dr. Lemi, you have the floor.
Thank you very much, Dr. Farid, for the kind introduction. So today we will speak about termination of pregnancy in women with uterine scar. I have no conflict of interest to declare. So the objective of this webinar or presentation is to discuss about client evaluation and the special consideration in women with uterine scar, and to discuss about options of termination of pregnancy. So currently there is increasing cesarean section rate globally, and associated with this there is also increased morbidity related to pre-PCS like placenta accreta spectrums. And along with this, there is also a high rate of second trimester abortion, which is globally nearly to more than 15%. There is also high proportion of the medication abortion compared to surgical abortion worldwide, especially in developing countries. There is high rate of medication abortion compared to surgical abortion. There is a provider's concern that medication abortion in women with uterine scar is associated with increased risk of complications such as uterine rupture. So we'll see the evidence, because the evidence are limited, that whether the actual risk of uterine rupture with medication abortion is increased or not. So like any other patient with undergoing termination of pregnancy, termination of pregnancy in women with previous uterine scar should go through pre-abortion assessment. That includes complete patient history, target physical examination, and relevant laboratory workers. And the history should include reproductive history, past obstetric history, major medical problems, past surgeries, and current medications and allergies. Because this complete history, target physical examination, and the relevant laboratory workers will guide us on to decide on mode of termination of the pregnancy and the precautions that we should take during the process. Once termination is decided, there should be appropriate dating, gestational age determination. The recommendation for patients undergoing termination of pregnancy is to determine gestational age using menstrual dating and physical examination. That is abdominal exam to determine uterine size using tape measurement, and pelvic examination can be used as indicated depending on the individual patient situation. Just to briefly see the use of ultrasound in gestational age determination. Ultrasound can be used if available, but it's not a prerequisite to provide the care. For example, if there is discrepancy more than 2 weeks between menstrual date and uterine size by exam, ultrasound can be used to solve the discrepancy and plan the management accordingly. So this just so the use of ultrasound to rule out or exclude the possibility of placenta previa in second trimester termination of pregnancy. Both the risk of placenta previa and the risk of placenta accreta syndrome increases with the number of cesarean sections, especially those with 3 and 4 multiple cesarean sections. The risk of placenta accreta syndrome also increased, like in 3, it is 17 per 1,000. And in those with 4 and more, the risk of accreta is like 67 per 1,000. So it's good to consider the localization of the placenta and to rule out placenta previa in those with multiple uterine scar, because the risk increases with number of scar. So once the termination is decided, after appropriate client evaluation, what should come is informed decision making and the consent. So we providers are expected to provide sufficient and accurate information on available methods of termination, and also at the same time inform advantage, disadvantage, side effects, and potential complications of available methods. These information should be informed before, during, and after the termination of pregnancy. At the same time, there should be the information should be clear, objective, non-coercive, and provided in a language that the client understands to lead into informed decision-making and informed consent. The consent process should follow local protocol because there might be a minor difference from country to country, and also from within the same country, this might be variation from state to state. Coming to options of termination of pregnancy, which is one of the objectives of this presentation. In general, two options of termination of pregnancy in women with uterine scar, that's medical termination of pregnancy and surgical termination of pregnancy. Just to roughly generally compare the medical versus surgical abortion. These are the general thoughts about the medical and surgical abortion. So medication abortion avoids procedures and also any manipulations, and normally it mimics the process of miscarriage. It is controlled by women and may also take place at home, especially in those less than 10 weeks. This is what we learned more during the era of COVID, like self-medication and medication abortion at home for those at earlier gestational age. However, the process might take time with medication abortion, and the timing might not be predictable and might need also more clinic visits. Compared to this, the surgical abortion is a quick procedure, and the process is takes place in health facilities, and the time is predictable, and the time is also controlled by healthcare professional providing the service. It's also easy to verify the complete abortion immediately by evaluation of the product of conception. The other advantage also might be sterilization or placement of IUDs at the same time of procedure. With the medication abortion further comparison, women experiencing bleeding, cramping, and potential some other side effects that are related with the drug, like nausea and vomiting. And also, if we see the use of medication abortion in women with uterine scar, which we are going to evaluate and go through the evidences today. With one scar, there is might be low, but those with multiple scar, we will see the evidence that are available. The other issue is the medication abortion is might be more expensive because, especially with advanced gestational age in second trimester, might require admission and also might take more time. Bed occupancy might be there, but can be provided by less trained health workers. Compared to the surgical abortion, it might be less expensive. It might be just an outpatient procedure with one-day visit, and but when we see the human resource, you might need trained health workers. Compared to the medication abortion, there is more risk of uterine or cervical injury, and this is not related with the number of scars. So regardless of number of scars, the risk of injury is in surgical abortion. So just to take you through some available evidences on medical termination of pregnancy among women with uterine scar. This is a study that's done among women undergoing termination of pregnancy in first trimester, that's less than 69 days, with mifeprostol and misoprostol. So 413 of them have one scar, and so the safety and efficacy were similar to what's reported in the general population. And in this first trimester termination of pregnancy with scarred uterus, there is no uterine rupture reported. Further going on, this is the study that's comparing women with 3 uterine scar, 31 of them with 3 uterine scar, compared to the controls, which are 107 with no uterine scar. They used a misoprostol 200 microgram given every 6 hours. So the gestational age is between 13 and 26. Normally, for clients with no uterine scar, the recommended dose is nearly 400 every 3 hours. So in this study, what you can see is there is a low, almost half, they used half of the dose of the recommended misoprostol, and they also increased the length between the doses of the misoprostol. So with this study, almost all other variables, outcomes were similar, like time to abortion, total misoprostol, and also adjuvant use of other treatments to complete the abortion process were similar, including severe hemorrhage and blood transfusion between the study group and the control group were similar. However, when we see the risk rupture and the risk of hysterectomy is more common in the control group. That is, there were 3 uterine ruptures that required hysterectomy among women with 3 uterine scars, and it was statistically significant with p-value of 0.06. Taking you through another study, which is a prospective study comparing clients with 1 scar, taking the same dose of misoprostol, which is 200 microgram every 4 hours, but they compared 1 scar before 20 weeks and after 20 weeks of gestational age. So with the same dose before 20 weeks and after 20 weeks, there is no case of uterine rupture, and the authors concluded that induction of labor with lower misoprostol dose appears to be safe and effective throughout second trimester in women with single previous cesarean delivery. Another retrospective study, in this study, is brought to see the use of loading dose and then reducing the maintenance dose of misoprostol. In this study, there were 431 women with 1 scar and 37 women with 2 cesarean deliveries. And they used 800 microgram of loading dose of misoprostol, and they used 100 microgram every 2 hours. So in this study, there is no woman who experienced uterine rupture. So in this case, they used loading dose of misoprostol, and then they reduced the maintenance dose to 400 microgram. But then the length between the 2 doses were 2 hours, which is narrow compared to the recommendations. So taking through the available systematic reviews on termination of pregnancy uterine scar, this systematic review is a systematic review done in early pregnancy failure or first trimester, and they had 488 women were included in this systematic review. Among these, 78 were with those with prior uterine scar. Among these, 1 CS 54 and 2 or more CS were 20, and 4 of the clients have 4 myomectomy scar. And in this case, also there were no cases of uterine rupture. So this is just first trimester termination of pregnancy among clients with uterine scar, and they reported no cases of uterine rupture. In another meta-analysis, which is conducted among clients with uterine scar undergoing termination of pregnancy at second trimester, that is above 13 weeks of gestational age, with misoprostol alone or combined regimens. In this study, 3 women suffered uterine rupture, and the calculated risk at day 0.28 with a previous scar and 0.04 without previous scar. In this review, they didn't consider, or they didn't do subgroup analysis or sensitivity analysis in line with the number of cesarean scars. So they, based on, without stratifying depending on the number of scars, they came with the conclusion that there is 440 women with previous scar given misoprostol, the risk of rupture is only 1. And this is also another systematic review in second trimester between 60 and 28 weeks among women undergoing termination of pregnancy. And in this systematic review, they came up with like the risk of uterine rupture with one prepular transverse cesarean birth is only 0.4, and it's not statistically significant. In the same way, there is no hysterectomy, and the risk of blood transfusion is only 0.5%. However, in this systematic review, they didn't come up with enough studies in women among containing multiple cesarean delivery. So they concluded that there are insufficient data on the risk with more than one prep cesarean birth or with classical cesarean deliveries. In recent and large systematic review, which is published almost 4 years back, in second trimester, they composed the termination of pregnancy among uterine scars in second trimester, not associated with increased risks of uterine rupture among women with only one CS scar. So in this systematic review, which is a recent one, the risk of uterine rupture with one scar is only 0.47. However, the risk of uterine rupture was substantially increased among women with more than 2 cesarean section, with relative risk of 17. However, when we consider the absolute risk in this systematic review, the risk of rupture, the absolute risk of uterine rupture were 2.5%. So in all these studies, primary studies, and also the 4 of systematic review, I just get through, there is no statistically significant difference between scar and without scar in terms of infection, endometriosis or sepsis, blood transfusion, induction to expulsion time, and number of doses of misoprostol that is required. So considering these evidences from the published literatures, so how we can take these evidences to recommendations? So moving from evidences to recommendations, just considering the ladder of level of evidence that we can get from published literatures. So systematic reviews at upper tier. So in this, I'll just go through the 4 of available systematic reviews. One of systematic reviews conducted in first trimester, and they showed that regardless of number of cesarean section, there is no increased risk of uterine rupture in termination of pregnancy among uterine scar in first trimester. 3 of systematic reviews were done among second trimester women undergoing termination of pregnancy. So one showed that there is a significant risk of rupture with CS scar, but with this systematic review, they didn't stratify or do subgroup analysis depending on the number of uterine scar. The other systematic review reported that there is no sufficient data to conclude for those with more than 2 CS scar, and the other systematic review, which is the recent one and containing large number size, they report that there is increased risk of rupture among those with 2 and above cesarean section scar. So, just summarizing the evidences from the published literatures in our move from evidence to recommendations, you can say that there is no clear guidance on medication abortion regimen from the published literatures because there are different scenarios on safety and efficacy of the drugs. However, we can summarize that there is no change in the medication abortion regimen for women whose gestational age is less than 10 to 12 weeks, regardless of the number of uterine scar. And also no change in medication regimen for women with 1 uterine scar whose gestational age is less than 22 weeks of gestational age. However, here we have seen different reports like those second trimester multiple scar undergoing termination of pregnancy were reported in some of the published literature as they are increased risk of uterine rupture, and also with 1 scar above 24 weeks of gestation. Even though the evidence are limited, the published literature that we have at hand have shown some concerns with the uterine rupture, which might require dose adjustment, and we will come with the globally existing recommendations on this slide. So to move from evidence to recommendations, what guide us is the evidence to decision framework, which is developed by the SIDE group. So this requires, we can come up with a recommendation depending on the available evidence. So these are the 6 domains of evidence to decision framework, which can guide us taking available evidences to recommendations. So these are the effects, that's benefits are, that is the evidence that we can get from the published literatures. And other things that we need to consider in our move from evidence to recommendation is values, equities, resources required, acceptability, and visibility. So depending on these, from evidence to recommendations, if we see the globally existing guidelines and the recommendations, so we see the World Health Organization Medical Management of Abortion Guideline, they didn't specifically say anything or recommend the regimens or how to use medication abortion in line with patients with previous uterine scar. The same goes with other existing institutions, including ACOG, NAV, NICE guideline, and also RCO, Royal College of Obstetricians and Gynecologists. They didn't specifically recommend anything for termination of pregnancy for patients with uterine scar. This is IPAS recommendation for patients with uterine scar. The IPAS recommendation almost goes with previous slide summary of available literatures that shows evidence on how to terminate, how to use medication abortion among clients with uterine scar. So they concluded that, recommended that less than 22 weeks, one scar, there is no change. And for those above 20 to 24 weeks with one scar, or above 13 weeks with two scar, they said there might be a need to reduce the dose or lengthen the dosing interval of misoprostol. However, they said that there is insufficient evidence to know if this impacts the risk of uterine rupture in this woman. So decreasing and increasing the interval of, whether decreasing or decreasing the dose and increasing the interval of misoprostol reduce the risk of uterine rupture if there is no doubt. So with this also, the recommendation is weak and the quality of evidence is also low. This is the recommendations from IPAS. The other recommendation is the FIGO 2012 recommendation. The FIGO 2012 recommendations recommended that to use half dose of the misoprostol for women with previous uterine scar and regardless of the number of uterine scar. So this is a study that is conducted to see the risk of uterine rupture by using the FIGO 2012 recommendations. So they reviewed the 160 women between 12 and 24 weeks of gestational age. Among these, 48 had one scar and 29 had more than one scar. So in this case, in line with the FIGO 2012 recommendations, they used half dose of the misoprostol, and they observed only one uterine rupture among which occurred in a patient with 3 prior CS scar that used 200 microgram sublingual. So FIGO updated the recommendations in 2017, and in 2017 recommendations, it says like misoprostol can be used for women with previous cesarean or other transmural uterine scar throughout 30 to 26 weeks of gestational age. Then they said, the FIGO said that there is insufficient evidence available to recommend a regimen of misoprostol for use at more than 26 weeks of gestational age in women who had previous cesarean or transmural uterine scar. So they said the experts and providers to follow a local protocol for those above 26 weeks with uterine scar and undergoing termination of pregnancy. This is the updated 2017 FIGO recommendations. So going through these literatures and also globally existing recommendations on medication abortion among women with uterine scar. This is the St. Paul's Hospital Millennium Medical College guideline that guides us termination of pregnancy among women with uterine scar. So we changed the dose of the misoprostol for clients with one periuterine scar after 20 weeks of gestational age. So after reviewing the literatures, we used the loading dose by halving the maintenance dose of misoprostol after 20 weeks of gestational age. And also the same goes for periuterine scar. We halve the dose after 13 weeks of gestational age. That means second trimester, multiple scars, that means 2 and above scars, we reduce the dose by half. And for those above 20 weeks, we use the loading dose and further reduce the maintenance dose. So this is the protocol that we use at St. Paul. And we have been using this protocol for nearly now 3 years. And we have many clients with uterine scar referred from different places. And we don't have a single uterine rupture with this protocol. The uterine rupture we have in the past 3 years while used with the medication abortion is in fact a woman without uterine scar. So taking you through surgical termination of pregnancy as one option of termination of pregnancy among women with uterine scar. Can be MVA or electrical vacuum aspiration, dilatation and evacuation, hysterectomy or hysterectomy, depending on gestational age and the specific diagnosis or indications for termination of pregnancy. Complications of surgical termination doesn't appear to be increased among women with uterine scar. Evidence also showed that there is no difference in approach of surgical termination of pregnancy among clients with uterine scar compared to those with the general population. There is no need of routine cervical preparation for clients less than 12 weeks, similar with other non-scarred uteruses, but we might use cervical preparation in those with exceptional circumstances, like with those with severely damaged cervix with from lip or other cervical procedures, adolescents, or with some exceptional case we might use, we might need to prepare the cervix among those with less than 12 weeks. For those above 12 weeks, standard cervical preparation using medical and or mechanical methods should be there, and this is recommended by existing by different institutions, including the Society of Family Planning, WHO, IPAS, and also we adhere to these international recommendations, and we prepare cervix before second trimester PND for those second trimester termination of pregnancy and having uterine scar. So in this process of termination of pregnancy among clients with uterine scar, there might be some special considerations that we might need to consider. Is there is increased cesarean section rates, and along with this, there is also increased risk of placenta previa and morbidly adherent placenta. Patients with placenta previa status and placenta accreta spectrum requiring an induced abortion on second trimester present high risk of massive hemorrhage during termination of pregnancy. So, for example, if we see this study is termination of pregnancy among 51 second trimester women with uterine scar and also concomitantly diagnosed with placenta previa and placenta accreta spectrum, and with gestational age up to 24 weeks. So in this study, there were two groups. One is planned, those who undergo the planned hysterectomy, and the other is who undergo medication abortion. Like 20 of them have hysterectomy and 31 of them have medication abortions. If you compare the risk of hysterectomy in both, 3 of the hysterectomy group undergo hysterectomy for hemorrhage, and only 1 among the medication abortion undergo hysterectomy for infection associated with retained placental consumption. However, among clients with among women with medication abortion, almost all of them require dilatation and evacuation. In 20 of the cases, because of the failed medical abortion, and in 10 of the cases, because of the difficult removal of the placental tissue. So even though the risk of hysterectomy is lower among those with medication abortion and adjuvant treatments, the risk of failed medication abortion is almost 100% requiring dilatation and evacuation. In another study containing 29 women containing diagnosed with uterine scar and also concomitantly contain complicated with placenta accreta spectrum, 7 patients underwent uterine artery embolization followed by hysterectomy, and placenta was removed at the time of the surgery. The remainder of them undergo medication abortion with adjuvant treatments, which includes uterine artery embolization, methotrexate, nifedipine, DDNDC. That means placenta is left in situ for the concomitant adjuvant treatment. So in this case also, 3 patients, which is 10%, requiring hysterectomy were in the hysterectomy group, in the immediate hysterectomy group, because of the massive hemorrhage. So there is a limited evidence and limited literatures that are published and existing currently for management of uterine scar complicated with placenta accreta syndrome during termination of pregnancy or second trimester. So we will see from these literatures, those who undergo hysterectomy are at high risk of having hysterectomy. And so the management depends on individual client conditions, the need for fertility, and the local resources, existing expertise, and also like existing technologies to manage associated hemorrhage like uterine artery embolization, and also monitoring like using serum beta HCG, the placenta is left in situ. And so there are multiple factors that can that might guide the management. So considering the limited evidences and also the cesarean section rates that's increasing and associated placenta previa and placenta accreta syndrome, we have this protocol as Centipol for placenta previa without any feature of adherence. That is, even though the evidences are limited in placenta previa, there is a tendency, and most of the experts also favors more of surgical abortion in patients with placenta previa. However, for those less than 20 weeks, both medical and surgical options are surgical methods of termination of pregnancy are optional. But between 20 and 40 weeks, the available evidence outweighs for surgical termination, that means DND, dilatation and evacuation, over medical abortion. Between 24 and 26 weeks, is the gray area where dilatation and evacuation or hysterectomy can be used, comparing the individual setup, expertise, and also the individual patient condition. After 26 weeks, even though limited, the existing literatures outweighs to use hysterectomy or cesarean section delivery if it is viable to be defined as cesarean section. The difficulty comes with when placenta previa is complicated with placenta accreta syndrome. And as we have seen, like 2 of the studies which are recently published on second trimester termination of pregnancy among women with placenta previa complicated with placenta accreta syndrome. So as I said earlier, the management might depend on individual patient factors like the need for fertility, and also the setup, the expertise, the resource, the available monitoring and the management technologies that are available in individual setup. However, the existing recommendations with limited evidence and also experts' recommendation goes for gravid hysterectomy and double setup DND for the management of placenta previa complicated with placenta accreta syndrome. Double setup DND is dilatation and evacuation that's done in the operation theater with all necessary conditions prepared to manage if any catastrophic hemorrhage happens during the dilatation and evacuation. Other options that are reported with the case seriousness and others is adjuvant therapies, like leaving the placenta inside and using adjuvant therapies like uterine artery embolization, which can be used prophylactic or post-procedure, and also hysterectomy and medical abortion with adjuvant treatment to manage the remaining placental tissue. This is what I have. Thank you.
Thank you, Dr. Lemi. Thank you, Dr. Lemi, for the nice presentation and the updated and scientifically exhausted review of literatures. Okay, so now the floor is open for discussion. I have collected a few questions from the participants online, and you are also welcome to raise your hand and ask questions directly to Dr. Lemi. But I will forward some of the questions I have received. So Santayo have asked, misoprostol dose in FIGO guideline for safe termination is based on gestational age, but WHO recommended the dose based on uterine size. How do you see these two conflicting guidelines?
Okay, so specifically the existing literatures on how to decide the gestational age, especially so for those with missed abortion and others, to decide with uterine size, because the existing systematic reviews and also internationally available evidence to use if there is a discrepancy between the gestational age determined by menstrual dating and fundal age, to use fundal age. However, like depending on evidences that are generated specifically in time, because the evidence are evolving and might change from time to time, and we might also need to consider the time when the evidence or recommendations are came in, because most of the institutions update the recommendations every 5 years. So every time evidence might change, but currently what's existing is to use fundal age as if there is any discrepancy between menstrual dating and fundal age to decide the dose of the misoprostol.
Okay, thank you very much. So there is one more question I can see online. So Dr. Hairamariam have asked, so when is the time to revisit the upper limit of gestational age in the definition of abortion, and are we there yet? I think this question is particularly relevant, important to many countries, including Ethiopia. But at the same time, this question is, well, there are many factors where countries decide on how they define abortion and how they set the upper limit. And there are many variations, even to the different factors that are considered when countries make such recommendation. And I feel like this is a question that is more or less related to policy, but can have a significant impact clinically. But at the same time, this is a policy issue that is usually informed by clinical outcomes. So very soon, I believe in the next 2 to 3, after 2 or 3 sessions, we will have another session on global abortion policies that will be presented on the same platform. And I really encourage you to join us for that session, where we will discuss the various policies and how the policies are informed and how those policies are affecting clinical practice. So I believe that this question will be addressed through that very session. Okay, do we have any other questions from online participants? Okay. In the meantime, I think we can discuss the take-home message from this session. Okay. So for us, it's having clients with 1 or 2 or even more cesarean scar present for termination of pregnancy is not.
Maybe Shimali's question is right. Shimali's question is, what specific measures can be done for women undergoing abortion with placenta accreta spectrum? So yeah, thank you, Shimalis, for your question. Management of clients, women with previous scar complicated with placenta previa and placenta creta spectrum. You know, the evidence are limited and they are based on reports from case series and retrospective studies. So along with this, the management should depend on local resource, the available resources, the expertise, the client desire, that is the future fertility, and also available technologies like, for example, availability of uterine artery embolization, monitoring like serum beta HCG, and the others. So depending on these situations, we can frame our management for patients with placenta creta syndrome. For clients who don't desire future fertility or who have completed their fertility size, it is from the experts' opinion on also available literature evidence, it's wise to go for a gravity hysterectomy as is recommended with low risk of hemorrhage and also associated morbidity. But if the woman desires to have future fertility and complete fertility size, depending on the risk of hemorrhage and others, so providers can decide if it's possible to conserve the uterus, like with hysterectomy, a medication abortion, or double setup DNA, which is actually more recommended than other methods, and use adjuvant treatments further. These are the available evidences, but the decision is, you know, it is not black and white. So this should depend on decided on individual basis and patient factors. We have like a couple of patients with placenta, second trimester placenta creta syndrome. For some of them, we managed to have hysterectomy, and also we have DNA cases. And there is also a case where we have done gravity hysterectomy. So decision should be individual. Yeah, thank you. That's what I can say. Maybe Farid, if we can add anything further on this.
Okay, yeah, thank you very much. I think this is one of the nuances when it comes to managing patients with morbid adherent placenta or placenta adherent syndrome requiring for termination of pregnancy. And like, because this is something that is happening very recently, and because of the rising number of cesarean sections that we are facing these cases recently, and it's very hard to say based on, you know, limited evidences. It's very difficult to make a strong recommendation to do what. But based on available evidences, there are some places, there may be some place for, you know, uterine preserving interventions, but again, that should consider into the availability of local resources and also expertise, where you can strictly follow the patient. If you try to do like leave the placenta inside, and you know what will be the risk of infection, what will be the risk of having secondary hemorrhage. So all factors have to be taken into consideration, and at the same time, you know, a thorough discussion with the patient should really be done. Okay, so one more question for you is, would it be different if the same would be applied if the uterine scar is in fact from myomectomy scar, not from cesarean scar?
Yeah, thank you for the question. So normally we consider uterine scar as cesarean section scar, and also we count one scar, myomectomy scar, as one cesarean section scar, and manage accordingly.
Yeah, it's just based on extrapolation. Like most of the studies did not specifically mention myomectomy scar as a separate entity. So it's based on extrapolation, but otherwise we don't have like a direct head-to-head studies that looked at myomectomy scar. So if we don't have any more questions, Dr. Lemi, can you just summarize this? What is the take-home message, okay, with regard to patient is presenting with 1 or 2 or 3 or even more cesarean scar and have request for termination of pregnancy? What should be the approach, but medical versus surgical? Because for many years, there is a concern among healthcare providers, particularly with regarding the risk of uterine rupture. But nowadays, again, the morbid adherent placenta is becoming another reason for concern. But the main concern is what will be the risk of uterine rupture, and how should we, counsel patients to have the, you said we have two options of termination of pregnancy, either the medical or surgical. So how should we counsel about this?
Yeah, thank you, Dr. Farid, for providing this question, like the take-off message and the recommendations and also conclusions from this presentation. The provider's concern is not without reason. That we can also see that from literatures, because especially for those with multiple scars, there is increased risk of uterine ruptures, as it is evidenced from some of systematic reviews, especially large systematic reviews that are published like 3 or 4 years back. And also individual studies have shown us that there is an increased risk, there is a concern, and most of the studies, if you see, they used the reduced dose of misoprostol for those with multiple scars. So considering all these things, even though there is no strong justification, a strong recommendation, or strong evidence that can to justify or recommend surgical abortion against medication abortion, but the concern is there, and the concern is true when we see that some of the published literatures. So there is somehow the safety of surgical abortion outweighs compared to those medication abortion, because the evidence shows that the uterine injury or cervical injury associated with second trimester surgical abortion is very low. And in fact, the good thing is it will not, evidence shows that it do not increase with number of scars. So it is almost similar with the general population and those with uterine scar. And for medication abortion, the risk, the safety and efficacy is not similar between those with scar and those without scar. And in fact, it's not similar between those with one scar and those with multiple scar. So even though there is no strong evidence to recommend surgical abortion over medication abortion, but there are some clues that the safety of surgical abortion in second trimester with multiple scar outweighs compared to the medication abortion. That's what they can say, depending from the practice, also from the available evidence that we have.
Thank you very much, Dr. Lemi. I think that's a very important message for us. I mean, we are working with a very limited evidence at hand, okay, particularly with when it comes to women having multiple cesarean scar. And given how cesarean section is becoming a common procedure, not only in developed countries, but also in developing countries, I think it's high time where we should have a high level evidence to inform our practice. So that way we may, give patients the appropriate counseling before we decide mode of termination. So we have one more patient from Polyfield. So is there any recommendation for women with uterine scar from repaired infected uterine dehiscence?
Okay, yeah, thank you for the question, Polyfield. So this patient comes in, for example, in term pregnancies when we decide to allow for VBAC or not. So those with repaired uterine rupture, infected uterine, repaired uterine rupture, those with dehiscences that are repaired, most of the time we don't allow them for laboratory delivery. We directly decide them for cesarean section. So it's really difficult to extrapolate this evidence to those undergoing second trimester abortion, because there is no subgroup analysis or sensitivity analysis in those literatures that we reviewed. There is no single paper that did subgroup or sensitivity analysis, what to do among clients with previous repaired uterine rupture. So therefore, in the absence of literatures or evidences to suggest one, I can say it's good to consider individual patient factors and have also local experts' decision considering all the scenarios. Otherwise, there is no single thing to say that can say medication abortion is absolutely contraindicated for them. But as I said earlier, when we see for those with multiple scar, without compared with medication abortion, even though it is, strong enough, there is some clue that surgical abortion might be better. So there is no strong evidence and the justification to recommend against medication abortion. There are clues from the literature that surgical abortion might be better for those with multiple scars. So extrapolating that evidence, I can personally say that for those with repaired uterine rupture, previously uterine rupture that's repaired, might be better to consider surgical abortion than medication abortion using mifepristol or misoprostol alone.
I think this is, we know how the evidence is very much limited when it comes to women having cesarean scar. And I can imagine it will be even more limited when it comes to dealing with patients who have a repaired uterine rupture. So I think it's one of the areas where we will have to use our clinical judgment and make the decision based on several factors rather than it's unlikely that we will have any strong recommendation to go for or against any of the methods of termination of pregnancy. But this is where clinical judgment will have to play a role. Okay. Any more questions? I think we have addressed all the questions. Yes, I think we can call it a day. So I think it was a very productive session. I think Dr. Lemi have given us a very good, evidence-based discussion on management of a patient for termination of pregnancy for those with uterine scar. So before I wind up, I would like to thank all those people who have joined us today. This is the first session for the many to come in the future. And before we close, again, I would like to pass my thanks to the participants. And I'll leave the floor for this fact.
Thank you, Dr. Farid. So I think the overall take-off message for the researchers out there is to be engaged in similar research, because this is an area where evidence is lacking very much. So saying this, thank you very much, both the presenters and the moderators. Before we close the session, there will be a survey which will be broadcasted to the screen, to your screen. So the survey will really help us to improve our subsequent webinars. So I encourage everyone to fill the survey before ending your time. So thank you so much, and see you again in 6 weeks.